Here we have an image of the brainstem from the ventral view. We want to talk about the cranial nerves. You can see here how the first cranial nerve is closely associated with the cerebrum, and you can follow its course as it travels towards the cribriform plate of the ethmoid bone. Then cranial nerves 2, 3, and 4 exit at the level of the midbrain. Cranial nerves 5 through 8 exit at the level of the pons. And finally, cranial nerves 9 through 12 leave at the medulla. Nerves 3, 6, and 12 are located medially, and the remainder are located laterally. All of the cranial nerves exit ventrally, except for the trochlear nerve, cranial nerve 4, which exits dorsally and then wraps around. When you look at the brainstem from the dorsal view, you can note that there is midbrain consisting of the midline pineal body and the superior and inferior colliculi. The superior colliculi mediate vision, and the inferior colliculi are responsible for hearing. Paranod syndrome is seen with lesions that compress the dorsal midbrain, such as pinealomas or hydrocephalus. The symptoms include impairment of vertical gaze, especially upward gaze, due to involvement of the superior colliculi, large irregular pupils, ptosis, and impaired convergence. The cranial nerves are very commonly tested, so if you don't know them already, you need to spend some time memorizing this chart and really knowing them. Every time you do a physical exam during third year, you're going to be testing the cranial nerves over and over again, so you might as well learn them now. As you know, there are 12 cranial nerves. Luckily, most of them are pretty straightforward. The olfactory nerve mediates smell, the optic nerve mediates sight, etc. Now, the oculomotor nerve mediates 4 of the 6 extraocular muscles. And what are the other 2 cranial nerves mediating extraocular muscles? Well, we've got 4, which mediates the superior oblique, and then 6, which mediates the lateral rectus movement. Now, cranial nerve 3 also has a parasympathetic component which mediates pupil dilation, accommodation, and also production of aqueous humor. It also sends fibers to a small muscle called the levator palpebrae, which opens the eyelid. The trigeminal nerve, or cranial nerve 5, primarily mediates sensation to the face. The only motor component of 5 is the muscles of mastication, meaning chewing. The facial nerve, cranial nerve 7, controls the muscles of the face except for the muscles of mastication that are controlled by 5. 7 also mediates lacrimation from the eyes and secretions from all the salivary glands except for the parotid gland. So which nerve mediates the parotid gland? That's cranial nerve 9. The facial nerve also mediates taste from the anterior 2/3 of the tongue through the chorda tympani. And which nerve is it that mediates taste from the posterior third? It's also cranial nerve 9. Now we'll mention cranial nerve 8, the vestibulocochlear nerve. This goes from the ear to the brain, so it of course mediates the 2 functions of the ear, hearing and balance. The glossopharyngeal nerve, cranial nerve 9, the major functions include taste from the posterior tongue and control of secretions from the parotid gland. The vagus nerve. This is one you definitely want to know about. Cranial nerve 10 is the major parasympathetic nerve that innervates visceral organs all the way down to the splenic flexure of the colon. It also mediates taste from the epiglottis region, swallowing, and palate elevation. The accessory nerve, also known as cranial nerve 11, is a pure motor nerve to the sternocleidomastoid and trapezius muscles. Last, the hypoglossal, cranial nerve 12, is also a pure motor nerve that mediates the muscles of the tongue. As you saw on the diagram from another slide, nerves exit the brainstem from certain points, and obviously they must be coming from nuclei. Now, the midbrain is the source of cranial nerves 3 and 4. The pons is where nuclei from 5 through 8 lie, and then the medulla hosts cranial nerves 9 through 12. Recall that medial nuclei are motor. That is one mnemonic that may help you remember where these different nuclei exist. Cranial nerve reflexes have both afferent and efferent components. The corneal reflex is when you brush the cornea and the eyes will automatically blink. Sensation in this reflex is mediated by V1, and the blinking is mediated by a branch of the facial nerve. This reflex is useful for testing cranial nerve function in a comatose patient. That same branch of the trigeminal nerve, V1, when stimulated can cause reflex lacrimation and tearing. The efferent branch of this is carried by cranial nerve 7. If there is some compromise in these cranial nerve nuclei, losing this reflex does not necessarily mean someone cannot produce emotional tears. The jaw jerk reflex is elicited by tapping the jaw and looking for clenching of the masseter muscles. This would be abnormal and a sign of hyperreflexia similar to the Babinski sign. It is mediated by V3. The pupillary reflex is what we all see in a normal exam. When we shine a light into one eye, there is pupillary constriction. It's mediated by cranial nerve 2, which senses the light, and cranial nerve 3, which causes the pupillary constriction. Last, we'll mention the gag reflex, which is also mostly used to examine patients in coma. You stroke the pharynx at the back of the oropharynx, and the patient's palate will elevate. This is mediated by cranial nerves 9 and 10. Now let's talk about the vagus nerve. The vagus has three major functions. It has a motor component to the pharyngeal muscles for swallowing and the voice box for speech, a parasympathetic component, and it mediates sensation in certain areas. Each function of the vagus has a separate nucleus that encodes information. The nucleus solitarius obtains visceral sensory information and is responsible for mediating appetite and taste. Cranial nerves 7, 9, and 10 all synapse in this nucleus. The nucleus ambiguus is the origin of 9, 10, and 11, and it mediates motor production of swallowing, palate elevation, and speech. Last, the dorsal motor nucleus is the parasympathetic nucleus to the heart, lungs, and digestive tract all the way down to the splenic flexure. There are many holes in the skull, called fossa or foramina, that the cranial nerves and other structures pass through to exit the skull. We'll go through these from anterior to posterior. Most anterior is the cribriform plate. This is not a single opening, but actually a meshwork of many tiny holes that cranial nerve 1 passes through. Remember, 1 is for the sensation of smell, so this lies above the nasal cavity. It's actually in the ethmoid bone. Next, on the sphenoid bone, we have the optic canal. This is where cranial nerve 2 passes through on its way to the eye. The blood vessels that supply the eye pass through here as well, and they're called the ophthalmic artery and the central retinal vein. Lateral to the optic canal is the superior orbital fissure. Cranial nerves 3, 4, V1, and 6 pass through here, in addition to the ophthalmic vein and sympathetic fibers. Now, cranial nerve V2 passes through the foramen rotundum, which is round, and cranial nerve V3 passes through the foramen ovale, which is more oval-shaped. Note that cranial nerves V1, V2, and V3 pass through the skull in numerical order, 1, 2, 3, from anterior to posterior. One mnemonic that we suggest is that the divisions of cranial nerve 5 exit owing to standing room only. SRO for superior orbital fissure, rotundum, and ovale. The last foramen in the sphenoid bone is the foramen spinosum. This is not for cranial nerves, but the middle meningeal artery passes through here, so you should definitely know about it. Another mnemonic that may help you is ROS, Review of Systems. This stands for rotundum, ovale, and spinosum. The posterior cranial fossa includes the temporal bone and occipital bone. In the temporal bone, we have the internal auditory meatus, which cranial nerves 7 and 8 pass through. The jugular foramen is at the border of the temporal and occipital bones, and cranial nerves 9, 10, and 11 pass through here. The hypoglossal canal is the small hole in the occipital bone which cranial nerve 12 passes through. And last but far from least is the foramen magnum, which is the exit point for the brainstem, vertebral arteries, and also the spinal roots of cranial nerve 11. Here we have an excellent image of the cavernous sinus. The cavernous sinus is a collection of venous sinusoids located on either side of the pituitary that receives venous blood from the eye and superficial cortex. I'll outline it just so we're all on the same page. You can see how there are a lot of structures passing through the cavernous sinus. Ultimately, blood drains from here to the internal jugular vein, just like all venous sinus fluid. And this sinus is important because of these structures that are passing through it. So, what exactly is inside the cavernous sinus? Well, we have cranial nerve 6, which lies closest to the internal carotid artery. Additionally, there's cranial nerves 3, 4, and V1, which run along the lateral wall of the cavernous sinus. V2 also runs through it for a short distance before exiting via the foramen rotundum. There are sympathetic fibers that pass through this area as well. So, if a patient were to develop cavernous sinus syndrome, she would experience ophthalmoplegia due to involvement of cranial nerve 3, 4, and 6, and ophthalmic and maxillary sensory loss from involvement of V1 and V2. We now have some cranial nerve lesions to discuss. To truly understand the effects of these lesions, you must know the pathway of the cranial nerve. It's all about the neuroanatomy. Cranial nerve 12 mediates the hypoglossal muscles. If it's damaged, to which side does the tongue deviate? It goes to the side of the lesion. Cranial nerve 5 mediates mostly sensory, but it has a small component to the masseter muscles. A positive jaw jerk sign deviates to the side of the lesion, suggesting an upper motor neuron deficit. When there's a problem with cranial nerve 10, the vagus, the uvula deviates away from the side of the lesion when one says, ah. In cranial nerve 11, the way the SCM inserts means that it mediates turning the head to the opposite side. Thus, a lesion in the SCM manifests as weakness turning the head to the contralateral side. Hearing loss is a very complex topic, but it is infrequently tested on step 1. For now, the one concept you should understand is the difference between conductive and sensory neural hearing loss based on simple tuning fork tests. The René test compares the sound the patient hears with the end of a vibrating tuning fork pressed against the mastoid bone to the sound when the tuning fork is held upright next to the patient's auricle. When the latter sound is louder, meaning that air conduction is greater than bone conduction, you have a normal result. If bone conduction is louder than air, the René test is abnormal and the patient may have a conductive hearing loss. The second test is the Weber, which involves placing the end of the vibrating tuning fork in the middle of the patient's forehead. You can try this on yourself if you have a tuning fork handy. Normally, you should hear the sound equally on both sides, although some people will say they can't hear anything at all. Now, if you put your finger in your ear, you will hear the tuning fork only on that side. This simulates a conductive hearing loss. The Weber test lateralizes to the affected side in conductive loss. While in sensory neural hearing loss, since the nerve does not work, it sounds louder on the unaffected side which has a normal nerve. The second test is the Weber, which involves placing the end of the vibrating tuning fork in the middle of the patient's forehead. You can try this on yourself if you have a tuning fork handy. Normally, you should hear the sound equally on both sides, although some people will say they can't hear anything at all. Now, if you put your finger in your ear, you will hear the tuning fork only on that side. This simulates a conductive hearing loss. The Weber test lateralizes to the affected side in conductive loss, while in sensory neural hearing loss, since the nerve does not work, it sounds louder on the unaffected side which has a normal nerve. We also want to differentiate upper from lower motor neuron lesions in the face. Upper motor neuron lesions can occur anywhere from the motor cortex to the facial nucleus in the pons. This would manifest as motor weakness on the contralateral side. Lower motor neuron lesions occur anywhere along the facial nerve, and you would get motor weakness on the ipsilateral side. Let's talk about forehead involvement. The forehead is bilaterally innervated, so if an upper motor neuron is damaged, there is innervation to the forehead from the other side. Thus, if there is any problem using the forehead muscles, it must be because of a lower motor neuron lesion, as it is very rare for both hemispheres to be affected. Bell's palsy is the paralysis of one side of the face. There is a very broad differential, and it can be difficult to figure out the underlying cause. Things that you would want to consider for Bell's palsy include AIDS, Lyme disease, herpes, sarcoidosis, tumors, and diabetes. It is usually treated with prednisone, although most cases do resolve on their own. Now we'll mention the muscles of mastication. It takes 3 muscles to close the jaw and 1 to open it. The 3 muscles that close the jaw are the masseter, the temporalis, and medial pterygoid. The muscle that opens the jaw is the lateral pterygoid. All of these are innervated by the trigeminal nerve V3.